we're going to take a kind of a different tour this time. And I want to talk about mild traumatic brain injuries. And I don't know how many of these folks you guys end up seeing. My guess is if you do see them, it's because their recovery went bad or wasn't well managed in the first place. So I want to go over mild traumatic brain injury and what that really is and what it's not. And we'll talk about some of the risk factors for it going bad. We'll talk about the pathophysiology briefly, and then some other neuropsychological issues, and then we'll talk about vocational re-entry for these folks. So I hope it's of interest. It looks like we're a fairly small group here. And so fire questions at me when you have them, and I think I'll be able to see them here. So yeah, thank you. Okay, let's talk briefly about mild traumatic brain injury. There is a lot of mild traumatic brain injury, so the incidence is much greater than moderate and severe head injury, which is not a good thing, but there are 4,000 a day in the United States, or every 3 minutes. You can look at that over here in comparison to what you see over here. So the estimated average annual number of brain injuries based on data from 2002 to 2006, we see 52,000 deaths a year from brain injury, 275 hospitalizations, 1,000,003 ER visits, and we have no idea how many occur but never reach an emergency department. And so the incidence, you can see here, we've got 1,000,004 emergency department visits, but I'm sure it's much more than that. So. The cause of traumatic brain injury overall, this is changing. This is what's happening is you'll see that motor vehicle accidents and being struck by or against something. Actually, this number is down. This motor vehicle accident or crash incidents is down. Fortunately, secondary to our shoulder belts and seatbelt use and so forth. What is up are falls, and when you look at the demographics of head injury, now we have a bimodal distribution. We still have the 20 to 25 peak due to risk-taking behaviors, but now we got a peak around 60 to 75, age 60 to 75 because of aging, and people living longer, and as a consequence, people falling more. So I don't know how many people I've had this year that were out on the ladder cleaning their eaves troughs at age 70 or sawing limbs off of trees at age 70, but I can tell you that I've certainly had more of them than in years past. By severity here, you'll see what I was commenting on earlier. Of TBI, 70% of these folks are mild traumatic brain injuries without persisting symptoms. That is, if you do a quick summary of the research, if someone truly has what is defined as a mild traumatic brain injury, the vast majority of those folks are symptom-free in 3 to 6 to 9 months, if it's not a complicated mild traumatic brain injury. So 70% of these folks fall into that camp. 15% of patients with initially a mild TBI will have persisting symptoms, and then 15% have moderate to severe traumatic brain injury, which is the folks that you routinely see. So in Indiana, we estimate that there's about 10,000 every year brain injuries, traumatic brain injuries alone, which means that there's going to be about 1,500 mild traumatic brain injuries with persisting symptoms. And these are the folks that I want to kind of target today, because more than likely they will get to your office, and I hope they do get to your office because they often need help. So now let's talk about what mild traumatic brain injury is. There's a variety of ways to classify the severity of a brain injury. And so we can talk about the loss of consciousness, how long that occurs. We can talk about post-traumatic confusion, and we can talk about the Glasgow Coma Scale. And all three of these are used when we determine the severity of an injury. However, there are problems with each one of them. So the issue of loss of consciousness, it's hard to ask someone how long they were unconscious. It's kind of an oxymoron because usually we're not keeping track of time when we're unconscious. And so, you know, sometimes an injury is observed. So when you got an observer there, then you might get a reliable report of how long the person was unconscious, and you may not. It also may be the case that, if consciousness resumes when an EMT is present, then you might get some fairly close approximation of how long loss of consciousness was. But it's graded into three levels: mild, moderate, and severe, as you can see here, depending upon, well, there's many factors that influence that. The other thing that affects estimates of loss of consciousness, as well as the next one, post-traumatic confusion, well, and actually all three, the Glasgow Coma Scale, is that now it's a protocol, it's a medical protocol often to sedate or paralyze someone chemically when they've had a traumatic brain injury for a variety of reasons. And so there's some data to suggest that that may be neuroprotective to sedate someone in the acute phases of traumatic brain injury. So of course, if they're sedated, they're going to and rendered unconscious. That influences your estimate of how long that duration of unconsciousness occurred by virtue of the effects of the brain injury. It also influences the next one, which is post-traumatic confusion. Sometimes it's referred to in the literature as post-traumatic amnesia. I prefer confusion because it's not just a disorder of memory. Post-traumatic confusion refers to a constellation of neurologic symptoms. The most compelling thing about post-traumatic confusion is the amnesia in many respects. Many people with concussion and mild traumatic brain injury have an epoch of time after their injury where they are not forming new memories. So I've had many patients come to me that were in an injury. They were taken to the emergency department. They were evaluated and released because they were doing fine, only to tell me that they have absolutely no memory of going to the hospital, of being in the emergency department, and going home. So they are able to say their name. They might even be able to tell you the date. They might even tell you where they live. They might tell you all the basic information that triage nurses tend to ask, and yet not be forming a single new memory. And the reason for that has to do with the neurobiology of memory that we're not going to dive into too much at this point, but basically the injury has arrested the download process, if you will. And so that may last for seconds, and it may last for weeks, depending on the severity of injury. So post-traumatic amnesia is part of post-traumatic confusion. People with more severe injuries tend to have also a variety of what look like psychiatric kind of features. So they may be aggressive, they may be combative, they may be quite disoriented at the time, they may be really impulsive, they may wax and wane rapidly from being lethargic to hyper-excitable. And so post-traumatic confusion requires careful team and pharmacologic management because these patients can be difficult. They can hurt themselves or others during this period of time. But this is not it is not a psychiatric disorder by definition. It's a neurologic condition that's affecting cognition and behavior. Nonetheless, we use the duration of post-traumatic confusion as another way to classify the severity of an injury, and you can see the 3 different levels there. And then lastly, the Glasgow Coma Scale. So I'm sure many of you are familiar with this. It has 3 parts to it. It's a rating of how deeply unconscious someone is. Consciousness, of course, exists on a continuum, and in my case, it's quite limited at the moment, but I still am able to draw on a routine long-term semantically stored memory, fortunately. And so it can go anywhere from 3, which is a profound coma, to 15, which is a normal level of consciousness, at least based on these 3 different axes, if you will. And these are the Glasgow Coma Scale. I think most EMTs now, fortunately, are trained in the Glasgow Coma Scale, so we're getting much more reliable data than we were even 5 or 10 years ago. So these are the classification schemes, and so a mild traumatic brain injury by definition, as you can see, of course, is that they should be unconscious for less than 20 minutes. Their post-traumatic confusion shouldn't last over 24 hours. And their Glasgow Coma Scale ought to be at 13 or 15. Now, the other thing about the Glasgow Scale is that it's usually the earliest Glasgow Coma Scale that's obtained. And of course, before someone is sedated. So sometimes you'll see in charts that there are multiple Glasgow Coma Scales because they're trying to track whether they're in fact improving, or in the opposite case, if they would be declining in their Glasgow Coma Scale, which often means that there's a complication going on and they may need to do surgery. So this is how you would define a mild traumatic brain injury. So now let's talk a little bit about concussion grading, and let me just comment on that word. Concussion is a brain injury. It is a mild traumatic brain injury. It may be a metabolic or neurobiologic brain injury and not a structural brain injury, at least we can tell based on imaging capability. But concussion is a brain injury. So people often use that word as if to say, oh, well, it's no big deal, it's a concussion. Well, it may be no big deal, but on the other hand, it might be. So just to clarify that. So when we look at concussion or mild traumatic brain injury grading, the American Academy of Neurology has identified these 3 levels. So there's no loss of consciousness, no PTA or post-traumatic confusion, but a period of disorientation and confusion, which is another way to say delirium. And then there's level 2, which is no loss of consciousness, but now we do pick up some post-traumatic amnesia or confusion. So the patient wasn't unconscious, but they say to you, well, I don't know what happened for a period of time afterwards. And the family says, well, remember you did blah, blah, blah. And they say, no, gee, I really don't. So now you have a moderate concussion based on that PTA. And then in the third scenario, we have frank loss of consciousness that meets those original criteria. So now we have a severe concussion associated with level 3. So you would there's another classification scheme out there that works particularly well, developed by a colleague of mine at the rehabilitation hospital, Dr. Jim Malik. So this is a classification system for traumatic brain injury severity that has a little bit more scope to it. And this is research based as well. So you classify a brain injury as moderate to severe if one of the more of the following are true. So now we've got a loss of consciousness of greater than 30 minutes, post-traumatic amnesia of greater than a day. Their worst Glasgow Coma Scale in the first 24 hours is 13 or less. And they've got one or more of the following. They've got a hematoma or a subdural intracerebral hematoma, which of course is not a good thing you want to have. subdural hematoma, epidural, a clear evidence of a contusion or bruise in the brain based on imaging, or a hemorrhagic contusion, which you don't want, penetrating TBI, meaning like a gunshot wound, subarachnoid hemorrhage, or a brainstem injury. Any of those are automatically going to push your injury to a moderate or severe injury. Criteria B, if none of those apply, then you would classify it as either a mild probable, and so that means if one or more of these criteria apply, that is, the loss of consciousness is 30 minutes to less, PTA is 24 hours, or if there's a depressed basilar or linear skull fracture. And next is you would classify it as a possible traumatic brain injury if they had blurred vision, confusion, they were dazed, dizzy, if they had focal neurologic symptoms, which might mean like some aphasic symptoms or some paralysis on one side or the other, a nasty headache, and nausea, especially vomiting. So that kind of breaks it down in a different way. And also then the American Congress of Rehabilitation Medicine developed criteria for what represents a mild traumatic brain injury. And I'm not going to go into that because it's very similar to the others. I guess the issue here is and one might raise the issue of why is it so important to look at these criteria. Well, it turns out to be, of course, mild to moderate is a continuum. There's not a clear demarcation in many cases, and sometimes the Glasgow Coma Scale may give you a moderate injury, but the post-traumatic confusion may give you a mild injury. It's just important to try and gather as much information about the severity of an injury when you're thinking about the course of recovery. How do we evaluate them? When do we evaluate them? What resources might be anticipated? What can you tell the family? What can you tell the patient about what to expect so that you can normalize the trajectory of their recovery? Of course, it's a scary thing for the patient and the family. They don't know. So the more information you can give them about what's realistic and what's likely to occur, then the more likely you are to prevent or address other things that can come up in the course of recovery. So the point is patient education and family education and treatment planning is the reason to pay attention to these diagnostic criteria and what that may tell you on a go-forward basis. But I also want to provide this case study for you because this patient had a mild traumatic brain injury by all diagnostic criteria, and yet when we get into it, I'll be interested in your comments or your reactions about this as a mild traumatic brain injury. I'm offering this case because the relationship between acute measures of severity, if you will, and the measures of outcome, long-term outcome, are indeed nonlinear. And those of you who have been on this webinar in the past may know that I use that a lot. And indeed, if brain injury were simple, I guess. Well, I guess I wouldn't have a job. So that would be interesting. So, but it's certainly nonlinear, and you all know each one of these cases is so different. And I see Sandy Culp. Hi, Sandy. Sandy made the comment in here, mild traumatic brain injury seems like an oxymoron itself. And of course, you're right, exactly, Sandy. I certainly don't want to sign up for one, and I think I think it's important to be sensitive to how our brains are and how they function. My children, now that they are adults, tease me because I really did want to bubble wrap them and put them on a hanger until they were 30, but fortunately I didn't succeed. So anyway, so this is a 52-year-old woman who is driving down the road, and She is hit by a vehicle. Actually, she was hit by a limo, interestingly, going 55 miles an hour. She had a brief loss of consciousness, meaning in her case it was about 3 to 10 minutes, somewhere in that neighborhood. She was taken to a local emergency department by ambulance. She had a CT scan. She was within normal limits. She was released that evening to her husband. I didn't have any Glasgow coma scales. This was a remote rural hospital, and they did EMTs and the hospital staff didn't gather that data. She noticed, however, within a couple of weeks after her injury, that her vision didn't seem quite right, and so she went to a neuro-ophthalmologist and was found to have a possible sixth nerve palsy, cranial nerve 6. Cranial nerve 6 is involved in ocular motor control of your eyes, and she had what's called diplopia, or meaning that the eyes didn't align well, so she had some double vision. So then 2 months later, she was seen by an ENT because she was complaining of ringing of her ears, in her ears, or tinnitus, sensations of vertigo, impaired hearing, and headache. But she, like many patients, wanted to buck it up and wanted to go back to work, which she did, and she had resumed driving. So this patient was back to a full-time job and full-time work within a few weeks after injury. So I saw her 18 months after injury, after this mild traumatic brain injury, and in the examination it was clear that she'd also developed complete anosmia secondary to the injury. So she had no sense of smell, and no one had asked her that before, and I'm sure she thought I was strange for asking her, but we'll talk about the significance of that in a minute. And then with questioning, it was also clear that she was having huge mood swings, and she was doing things impulsively. She was disinhibited in her affect. She'd be spontaneously crying for 1 second, and then 5 minutes later was fine, and then 5 minutes later was quite happy, and then 5 minutes later throwing a tantrum and being irritable and angry, and so forth and so on. And then on examination, she evidenced bilateral visual field impairment. And I'll show you in a minute what that means, but her field of vision had been reduced in bilaterally, that is, out of both eyes. And on neuropsychological testing, she demonstrated clear impairments of new learning and memory. And this is 18 months post, quote, mild brain injury. So these are her visual fields. So if you look straight in the center of this figure, right here, that's your center vision. And then, so here's vision to the left, vision to the right, up and down, and so forth. So on examination, this patient had only central vision. All of these black areas were gone in this patient. And she was functioning in her day-to-day activities and really wasn't terribly aware that this impairment was there, but she only had central vision out of both eyes. So that was interesting. So she met the criteria for a mild traumatic brain injury. I'm going to back up a minute here because I need to, okay, here's a question. Is the black area the normal vision area? Yes. Good question. Ordinarily, you'd have, depending on age, we do lose some peripheral vision with age, but yeah, in a person of this age, you would expect to see a visual field that's about 30 degrees out in each direction. So yeah, so that does clarify that that's a substantial loss. So when we look at what's happening with this patient, I mentioned that she was anosmic. Well, right there, this is the base of the brain, and we're looking at the base of the frontal lobes right here. Here's the brainstem. Here are the cerebelli on both sides. Here are the temporal lobes, the temporal poles right there. We're looking at the bottom of the brain. These right there, those little projections you see coming out, are the olfactory bulbs. So those are your smeller. And here on the temporal lobes, there's some also some cortex called pyriform cortex or pyriform cortices on both sides. That cortex is involved in the perception and interpretation of smell. These guys are responsible for the sensation of smell. So it's not that she misperceives smell, she doesn't have any smell. So, sense of smell. So clearly this patient has injured her olfactory bulbs bilaterally. The skull's really rough right here, and so if brain slides back and forth on top of that rough skull, you can get injury to these olfactory bulbs bilaterally. So frontal lobes are also hugely involved in neurobehavioral stability and control. And I know you've heard that in previous webinars, but especially this mesial and frontal lobe region is responsible for regulation. Oh, that's interesting what I just did. I had no idea that I could do that, and I really didn't mean to do that. And so I'm very hopeful that that my esteemed colleague Ted, the technical genius, will. Oh, there we go. I figured it out. Okay. So sorry about that. So I have no idea where I was either. But frontal lobe. So these guys are hugely involved in the control of your emotions, and the reason for that is that this part of cortex, if you will, is sort of the executive center for managing your limbic system. So when your limbic system, the site of emotional experience, is going crazy, this part of your cortex says, no, it's probably not a good idea to do that. Let's soften that out. Rather than tear your boss's head off, let's just kind of say we have some concerns. And that's that frontal cortex that's driving and regulating that. So there we go. Okay, I did it again, Sandy. I'm sorry. So Sandy, okay. Sandy, I see that you said it's interesting that she's not aware that she couldn't smell any longer or that her vision was so constricted. That's absolutely true. Hi, Ted. So Ted has come to rescue me, fortunately. I don't know what I'm doing, but I think I figured it out. So, yeah. Thank you. So yeah, it is interesting that she didn't notice that. You know, characterologically, this person, Sandy, was someone who was highly focused. I mean, and her whole thing was, get me back to work. I want to go back to work. Well, she was back to work when I saw her. She wanted to get back to work instantly. High expectations in that respect. I think it was probably also some strong financial issues there. That is, I think she really needed her job. And by nature, this was a person who, you know, very much to the, you know, buck it up, let's get back to doing your thing. And yet, you know, here's a woman with a loss of significant peripheral vision, and she's driving. So that was the first issue that I had to address with her. So, and yes, it's interesting that she didn't, you know, the sense of smell. Although it's really interesting because sense of smell, you know, I've had many patients after we found that impairment say, oh gosh, yeah, I guess I hadn't thought about that. You know, it's something that I'm not sure we pay much conscious attention to when we are having a sensation of smell, other than when it's really pleasant or when it's really unpleasant. So yeah, I think the other thing that's interesting about that too, Sandy, is that of course frontal lobes are very much involved in monitoring our own functioning, and so this is hilarious. Okay, so I think patients with frontal lobe impairments are often unaware of their own impairments, and so it's also likely a function of that as well. So her impulsivity and affect disinhibition were certainly driven by impairments in this same region. And then this bilateral visual field impairment, where does she get that? Well, as it turns out, here is a closer view of this region here in the brain, in the central. This happens to be your optic chiasm. And if this brain wasn't anatomically dissected away from its cranial nerves and so forth, these are the optic nerves that then project out to the eyes. So that's been cut there, but this is called the optic chiasm right there. Injuries to optic, and then they kind of blend together, the fibers, if you will, from both sides, and shoot back then to the back of the brain, or to the middle of the brain in the thalamus, and from the thalamus back to the visual cortex. So this is one of the primary visual relay stations, if you will. And so injuries here at the optic chiasm cause bilateral peripheral vision loss. So we've got a patient with olfactory loss, affective disinhibition in the frontal lobes, and an injury to optic chiasm, all at the base of the skull here. And she's got learning and memory impairment. Well, she's having learning impairment because of her frontal lobe injury, and she's having memory impairment because of the temporal lobes right here. These right here, in fact, are the hippocampi, or the hippocampus of the brain, which is involved in translating new learning into memory. So information flows to these hippocampi, and the hippocampi say, oh, gee, I'd like to learn this, and they send it to look to the right part of the brain for long-term storage. So we have a patient here that's got no injury to all of the brain. I didn't include a picture, but you know, all this cortex throughout the brain is totally intact, and yet because of getting smacked at 52 miles an hour by a big vehicle, this patient obviously injured these regions of her brain at the bottom on this rough skull, causing this constellation of symptoms. And I present this case because then you'd ask the question, well, is that a mild brain injury? Well, by classification it is. But from a functional outcome perspective, it's not. So I thought it was interesting in that way. It looks like we got a, hi Steve, you've got a comment here, or a question, are there areas of the brain that are more prone to injury that is less protected than others areas? It's an excellent question. And I have trouble spelling too. So, but your errors are because you're in a hurry, and mine aren't. Yeah, in fact, these regions of brain are very vulnerable, Steve, because of what we just discussed. Anatomically, these are not smooth areas of the brain. They're rough areas of the brain, and the cranial vault on which this tissue sits is not smooth. It's got bumps and holes and ridges and so forth. And so again, sloshing brain around on this rough skull is not a good thing. I might point out also too that there was a question that she maybe had, the diplopia, the double vision, and that being a cranial nerve issue. Well, as it turns out, the cranial nerves emanate out of the midbrain and the brainstem right in this region also. And so it's not at all inconsistent that she had a subtle cranial nerve impairment. And because all of this is bone around here. And so, it was just an interesting case in that perspective. And there's another question here, is number one smell? So if, actually no, number one up here, that's referring to a particular region of the frontal lobes. That is, the olfactory bulbs are right here, and they're not identified numerically on this autopsy brain, but they're right there, the olfactory bulbs. This is one of the an important part of frontal lobes that's involved in regulation of mood and so forth. Okay, any other questions about this case? Oh, I should, yeah, there was something I forgot to add about this, though. This is why we have slides, so that it cues my memory. This patient was just getting ready to be divorced because of her changes in her behavior. She had been seen, I think, 3 times or 4 times by her general practitioner for all of this. She had been seen for neuroophthalmological evaluation with no follow-up, no referral to any kind of vision rehabilitation or anything. Her ENT diagnosed this vestibular problem, but that was it. And part of that was because she had crummy insurance. But here's a patient, I think in my report I had, 8 or 10 recommendations for treatment and intervention on, and that was after 18 months of living with this stuff. So I also just want to comment briefly here. I had a patient late last year that had a clearly mild traumatic brain injury as defined by these criteria, but he also had significant mood regulation deficits and attention deficits and executive function deficits. And this happened to be in a vice president of a major corporation. And so, as you might surmise, regulating your behavior and attending and having good planning and organization is important to most vice presidents and their vocational adaptation. This guy lost his job and his marriage within 9 months following, quote, mild traumatic brain injury. So I think these things functionally can be significant. Now, with that said, again, remember, most patients are normal within 3, 6, and 9 months post-injury. So that's the good news. The bad news is that we can't make the assumption that that's going to be the case, and that's why it's important we follow these people, and that's why it's important that vocationally we pay attention to what's going on with these people, because they can have some really unpleasant outcomes. And hi, Jeff. I didn't see you were on this call, but thank you for your usual humor. Jeff says, I know I've known a few folks who have lost their marriage within 9 months and they didn't have a brain injury. So, and maybe they did thereafter, I don't know. Yeah, and Sandra is back in. I do not understand how the areas that affect her memory and vision were injured by her skull. I thought the picture indicated that those areas were more in the center of her head. Okay, let me go back there. I wish I had a different image to show you. I should have a brain with the skull there. Let's see. Ted, is there a way to go online and pull up an image and put it on here? Or is that too complicated?
No.
Okay, here, have a seat. We're gonna fix this, Sandra. Here. Just Google image a brain and we'll find. Aren't we lucky to have Ted?
That's what everyone's saying.
Okay.
And what do you want to?
Just put in brain, and we'll get all kinds of, and then hit images. Okay. Let's see what we got here. So, okay, one place we can start is here. It still doesn't show you the skull yet, but this is from the side, Sandy, and notice, oops, I don't have my pointer anymore, but that's okay. Look at the brain on the, well, actually, look at the first brain. So to your left there is the frontal lobes, and you're looking right at the temporal lobes, and towards the back is the cerebellum and the brainstem. So you can kind of see from the side how that surface is, oh, so you can see my pointer. Okay, good. So you can see that this is not, so all of that is bone around there. Up here, see how smooth that is? Now let me see if I can find a different view. So this is my brain right here. My triple espresso is helping, but yeah, so, okay, let's see what we get. Here's a little bit more, if we look at it from the side. Oh, here we go. Here's a CT scan. So down here, you can see that all of that is bone there, Sandra. And that black part. The white part is brain. The white is high-density tissue, and the gray is less dense tissue. But you can see that all of that is bone right there. And what you still can't see is the... well, this is a cool image, guys. This image here is what's called tractography, and that shows you all of the different pathways in brain, connecting one part to the other, and proving the point that brains are less about parts and more about connectivity. Let's see. I don't know if that helps, Sandra. Well, yeah, if we had a, maybe if we had a, I'm going to put in a different search here and see if we can't find, here we go. Okay, so now, well, no, that doesn't, it still doesn't have the skull in there. Anyway, I hope that helps, Sandra. It's just not smooth down there is the best way I know how to describe it. And so it has some sharp ridges, and if this brain is sloshing across there, then there's going to be injury down there. So let's get out of, do I just click off this, Ted?
Yeah, just
shut that down?
Get you back on.
Okay. Okay. Ted has got us going here. Okay, I'm catching up on some comments. So, hi, Marcia. So will this presentation be available in written form? I'm perfectly fine with me. Ted, do you want to just send it to Carol Srott Bradley? And then, Marcia, why don't you just email Carol Srott Bradley and ask for a copy of it, if that's okay?
And this will also be...
the audio is available, too.
Video, the whole webinar. The entire webinar will be posted online.
So, and also, Marcia, all the other webinars we've done are available online too, and Ted can get you to those. So, okay. So, and then Sandra, yeah, it really is the skull, and it's just, that's the problem. Is the skull does a really good job of protecting our brain, and it protects these lateral surfaces in the top of the brain, but on the bottom is where these regions are vulnerable. Roger has a question about that Ted's going to answer.
It's on the Vocational Rehabilitation website online. You can go to vrs.in.gov, and I'm not exactly sure where it's located there, but it is located. You can also contact Carol, and she has all that information.
So hope that helps. Let me know if it doesn't. Okay, so I'm going to rock and roll here. Please, thank you for the questions and continue along. Let's talk about neuropathology a minute. So this is an important basic statement as it relates to mild traumatic brain injury. And you'll also see this says PCS, which stands for the post-concussion syndrome, which is another word that is a diagnosis that's used sometimes. It's not really a diagnosis. You can have a post-concussion syndrome because you have the flu, not because you have a concussion. So it's belies diagnostic accuracy. But as it relates to a true concussion or mild traumatic brain injury, Iverson said that there's little doubt that abnormal neurophysiology is the predominant cause of symptoms. So again, this is why the CT scans and the MRI scans, even if they had sufficient resolution, don't show anything, because this is a physiologic disturbance in minor or mild concussion or mild traumatic brain injury, or it can be. So we have to think about abnormal physiology. There's also a lot of research going on with respect to PET scans or positron emission tomography, which are scans of metabolism, not structure. And I published a study, I don't know, about 8 or 10 years ago with a colleague looking at positron emission tomography studies. And indeed, with that technology, you can sometimes see these impairments. So anyway, so 7 to 20% of patients that show up in an emergency room with mild TBI will show some abnormal head CT scan. So that's at least 80% and often 93% of people that meet criteria for mild traumatic brain injury have a normal head CT. There are cases, however, where they have what is referred to in the literature as a, quote, complicated mild TBI. So that's now the patient that meets all the criteria for a mild traumatic brain injury, but on head CT they pick up an abnormal finding, like a subdural hematoma or a small intraparenchymal hematoma or something like that. Head CT is abnormal in 5% of patients with a Glasgow Coma scale of 15, and abnormal in 30% of patients with a Glasgow Coma scale of 13. So there is a relationship between depth of loss of consciousness and damage to the brain. And these patients with complicated mild TBI have neuropsychological or cognitive or behavioral sequelae that are more similar to patients with moderate traumatic brain injury. They're more like patients with moderate TBI than they are like patients with mild TBI, and their prognosis is different. And so again, for diagnostic and prognostication reasons and for family education reasons, these data are important. So that's why neuropsychologists and people like me drive other people crazy asking for medical records. The presence of a structural abnormality on a CT scan argues for a causal association between injury and persistent cognitive symptoms. So yes, if you have a bad CT, you're more likely to have, quote, brain damage, end quote. You're more likely, not that you don't necessarily otherwise, but you're more likely to, that's going to potentially have persistent cognitive symptoms associated with it. In terms of the metabolic effects, as I said, most of these patients show perfectly normal structural imaging results. Concussive injuries really should be conceptualized as metabolic in nature. These cells, these little tiny microscopic cells live in this, and I'm not going to go into this in great detail, but these are fragile little puppies that rely on their connectivity of profoundly microscopic little connections. And if your brain is getting sloshed around inside, it's easy for the physiologic homeostasis of this milieu to be altered. The other issue, and this becomes clinically really important, because of the metabolic instability, then there is a significant change in the relationship between energy demand and supply. There's a mismatch, if you will. And that's why so many patients complain of cognitive fatigue after concussion. So their brain cells can't keep up with the processing demand. It's kind of like your working memory on your computer got cut in half, and so things process slower. And it just drives these patients crazy because they know their intellect is okay, but they can't use it, and they can't meet environmental demands because their processing speed is slowed. The brain becomes more vulnerable. So even if in normal waxing and waning of blood pressure, within the day or response, then these cells freak out and don't respond as well. We don't know how long this lasts. In animal models, it's usually a couple of weeks. We think it's probably much longer in human beings. This is where this issue of the second impact syndrome comes in. And do not let your children, whatever you do, play football if they've had a concussion until they're cleared. So I've had now 2 patients who came to me in a wheelchair and drooling on themselves because of 2, quote, concussions, end quote. And in both cases, they didn't listen to that advice. And so this is a real issue. When the metabolism of the brain has not stabilized from a concussion, your brain is vulnerable. And this is what sets the basis for the second impact syndrome. It's a real deal, and it's dangerous. It's generally speaking within the 72 hours. I think now in the most recent legislation, though, you have to be symptom-free. I'm not sure it's in the legislation. I think it's in the medical practice guidelines. I think you have to be symptom-free for at least a week or something like that. But take it seriously because it's a big deal. And you would think that a metabolic disturbance wouldn't leave us so vulnerable. But when we're talking about the brain, it does. A few of my patients with mild head injury are open to the idea of biopsy, and so we have to use animal models most of the time to look at microscopic changes, unless the patient dies from some other sort of medical complication. But if these are images of neurons or drawings of neurons, this is the cell axon. It exists within the glial structure. Ted is helping me here. I'm not doing something. Okay, there we go. Aha, thank you. So this is a cell axon. I thought I had a different image in here. No, okay. So this is a cell axon. It's been affected by mild traumatic brain injury. It's got these kinks in it, if you will. What this illustrates is that it's affecting what's called axonal transportation of these chemicals and biological materials down the axon. The cell body is up here. The axon terminals are down here. And chemicals are flying down through these axons to promote functions of the cell. Well, if you've got a kink in the hose, so to speak, then that's going to affect the metabolic efficiency or effectiveness of that cell. Here's a cell that's been even more injured, and so the axon has developed what are called something. They're called axonal something not good bundles, I believe, and so these guys now. You can see all the accumulation of these different organelles and chemicals and so forth within the axon, and now this axon's ability to transmit information from point A to point B has been severely affected. In the worst case scenario, that swelling then causes the axon to frankly break off. So now all of a sudden it's like a tree without the trunk. So that cell, the rest of that tree is ultimately going to die off, and that cell has been lost. Now again, there we are. It's called retraction balls. Thank you. Lobulation, that was the word I was anomic for. So that's what those guys are. So yeah, this nerve cell is going to die. And this happens in mild concussion. The good news is that our brains are very plastic and very stimulus responsive. So if that patient re-engages in activity, neighboring cells that weren't injured are going to grow new axon terminals and establish new connectivity. And so that patient may never have a bit of a long-term functional loss associated with the death of that neuron, or neurons as the case may be. Now this is an actual micrograph. So this person had some tissue under the microscope. These arrows show you, well, first of all, we should look at, here is a normal neuron right there. And there is a normal neuron as examples. This is a retraction ball, so you can see the swelling and the distortion of that. This is a retraction, the neuron with a retraction ball. So these are, when you get down to something microscopic, you can see these guys. No MRI or CT is going to show you that. Okay, so that's what a microscopic view looks like. What happens to these neurons over time is, at least in cat, these retraction balls and the swelling develop over the first 12 to 24 hours. There's also something else that happens that's unpleasant that's called Wallerian degeneration. And basically what Wallerian degeneration means is if this cell that's now going to die is hooked up to this cell, and this cell is hooked up to that cell, and that cell is hooked up to this cell. When this cell dies, now all of a sudden this one has lost maybe 60% of its relationship. It's dependent on input from this cell. Well, now this cell is going to start to atrophy. And if this cell starts to atrophy, then this cell is going to atrophy, and so forth and so forth and so on. So the bad news is that the patients may get worse for a period of time. And what bothers me a great deal is I often see people say, well, then this must be a psychiatric problem because they're getting worse, their injury occurred, there's no change in their CT scan, there's no reason to believe that they are getting worse. And as always, when we don't understand something, we blame it on the patient. So it must be that they're not coping or there's something wrong with their psychological resources. In fact, patients can get worse because of the neurochemical cascade that includes the evolution of these retraction balls and Wallerian degeneration. We don't know how long that happens in humans, but what we do know is that in many cases, post-traumatic seizures, for example, are the consequence of the brain's attempt to rewire itself but gone bad. And sometimes post-traumatic seizures don't occur until 3 to 6 months post-injury. So what that tells us is that this brain is a dynamic, evolving, structural, metabolic, neurophysiological substrate, and if it's evolving and changing, it can recover, and that can come out beautifully, and it can also go bad. So I think it's important to think about these things when we're thinking about the patient in front of us. Nancy, I see you got a question about the webinars, and I know Ted's looking at that issue now. He will post those on the same link. There we go. So I hope that takes care of that for you, Nancy. Now, you've all heard about diffuse axonal injury, and that's when these axons gets injured. That's when they get injured. That's what we're talking about. If it's bad enough, you do start to see them on CTs or MRIs, especially MRI. They do have a predilection for certain brain regions based on the density of brain tissue and its anatomical structure. So remember, this is the brain stem leading down to the spinal cord. And these areas of brain, this is the corpus callosum here. These are the thalami or the thalamus. Down here are the hypothalamus. This is upper brainstem, spinal cord. These guys are, quote, white matter, and that's because the neurons are covered with this white, with myelin, so that they can process information more quickly. And these are long tracks. These axons may be 2 inches long, but this tissue is very dense by virtue of its structure and organization. The cerebral cortex up here is less dense. So again, we've got a brain moving around within this enclosed skull, and if it's moving around, this stuff is going to be less resistant to moving, this white matter, and the gray matter is going to rotate or shift on top of it. So that, as a consequence, means is that there's more likely to be stretching of these neurons in the upper brainstem, because this thing's going to rotate on top of it. The corpus callosum is the next region where diffuse axonal injury occurs. And then what's called the choroidal plexus of the third ventricle. Down here is another region where that diffuse axonal injury occurs. Now, what that means functionally, your brainstem is involved in, first and foremost, in the regulation of consciousness. So that's why people go unconscious, is because they get enough diffuse axonal injury to the upper brainstem. And if you get a lot of diffuse axonal injury, that's when you go into coma. That's obviously the part of my brain that's not really on today. That is the battery. It is, we all have moment-to-moment, hour-to-hour, day-to-day fluctuations in, quote, consciousness, end quote. But patients will come in and they'll say, I just don't feel like myself. And they'll say, I just can't keep up. And in fact, these brainstem symptoms are often subjective and very hard to quantify, but that's what you see. The corpus callosum is this major highway between the right hemisphere and the left hemisphere. So it's like having your internet connectivity wax in and out, wax and wane, and it's on and it's off, and now it's at 90%, now it's at 20%, now it's at 70%. And so information processing efficiency starts to become compromised with diffuse axonal injury here. With the hippocampus, now we're talking about memory. And that's why so many of our patients have memory impairments and so forth. So this is, the diffuse axonal injury occurs in some fairly predictable levels and places, depending on the severity of the injury. There are psychological factors, of course, that affect how these symptoms are sustained or how these symptoms do get worse. So if I've already got an injured brain with some diffuse axonal injury, you guys have all been through the donut and the hole metaphor too many times, but if I've got underlying brain injury and now I get depressed, my symptoms are going to get worse. If I was already depressed when the injury occurred, now all of a sudden I've got a brain that's metabolically depressed or is starved of serotonin. How is that going to affect the expression of the injury that I just had? Sometimes psychological difficulties maintain symptoms. So this is an important concept. So you have a brain injury. You have some mild diffuse axonal injury. Your clever brain restores itself, hooks itself back up, establishes connectivity, But in the meantime, because you couldn't go back to work or because you were acting differently, now you get depressed. So now your hippocampi may function perfectly normally from a metabolic and physiological perspective. Your memory systems are fully on board, but you can't remember because you're depressed and you have a serotonin depletion. So sometimes these psychologic factors maintain symptoms. So when we do neuropsychological examination, we find totally normal memory, but the patient comes in with a boatload of memory complaints. You give them personality testing and they've got this whopping depression. Now all of a sudden you have the basis for why they may be saying that their memory is impaired. That doesn't mean they didn't have a head injury, but it means that they recovered from their head injury, but in the meantime managed to acquire a depression because they weren't managed or weren't monitored and followed in the right way. So these psychological factors are relevant and need to be taken into account. So I'm looking at the time here. I think I'll, no, I'm not going to talk about this. This is about this goes into detail about this whole concept of the post-concussion syndrome. This, as I said earlier, it's a garbage term. It refers to things like dizziness, nausea, I think a headache is in there, I'm not sure. I forget, I don't have that available right now, but if you look at 81% of patients with chronic pain, for example, no history of head injury, 81% of patients with chronic pain meet the diagnostic criteria for post-concussion syndrome, despite the fact they've never had a concussion, and so forth. So that digresses into that issue, and I'm not going to go there unless you guys tell me you really want to do that. These are important data. So when you look at severity of injury and you look at having additional injuries, that is, now all of a sudden the patient broke their leg, or they've got soft tissue injuries in their back or neck, in the same accident, they're more likely to have a complicated recovery. So 18% of people who sustained a mild traumatic brain injury and orthopedic or soft tissue injuries returned to work at 1 month, as compared to 88% of patients that had a mild TBI alone. So there's a huge influence there of whether you got other bodily injuries. I think that what that tells us, though, is something else, and that is that these patients who had only a concussion may have had less severe trauma to their body than these patients who got an orthopedic or soft tissue injury. It could be the case that it's just simply a more specific injury to head, but I think that in many cases it also simply means that the patient with orthopedic injuries got thrown around more than patients that had this, quote, pure TBI. A classic example of that are patients with falls. These guys often have, relatively speaking, quote, mild, end quote, TBI, but they come in with multiple complications, fractures and so forth, and they often have more protracted, difficult recoveries from a cognitive and behavioral standpoint. So I just thought this was interesting because it's not just an issue of injury to your head. Looks like we got a question. Hey, Tom. So was this return to work part-time or full-time or supported? I know that it was not supported employment. Whether it was full-time or part-time, I don't know. Yeah, sorry about that. These were obviously patients that were recovering pretty quickly from their injury. So, okay. I'm going to pass over that. Okay, so now I'm going to talk about diagnosis from a neuropsychological standpoint. And I'm not going to talk about this too long, but it's, yeah, in fact, I need to, do we know what slide number that is, Ted? I'm trying to figure out where I am in the material I've got, because I want to get to the vocational rehabilitation of these folks, and I don't know where I am.
Did you click it?
Well, that's okay. I'll fake it, Ted.
Okay, click it again.
Yeah. Okay. Yeah, we'll get there. Okay. So neuropsychological diagnosis. So the first issue, obviously, is there an impairment of brain function present? Is the first issue that we're going to do when we do a neuropsychological examination of a patient with a suspected or known mild traumatic brain injury. And is it consistent with the pathology? What are the primary impairments and what are the secondary impairments? And by that I mean, for example, if you have an upper brainstem injury and now your cognitive battery has been impaired, you have less cognitive energy, you have less speed of information processing, of course that's going to have a global effect on cognitive function. So now your memory is not going to be quite as efficient. Your executive functions aren't going to be quite as consistent. So you may have a primary impairment of brainstem functions. You may have perfectly normal hippocampi or perfectly normal frontal lobes, but because they're not getting activation from the upper brainstem, you may show secondary consequences of that impairment in other areas of function. So in a way, now you have other impairments because of the effect of this more primary area of functioning. And then last, what is the effect on your daily life, and what does that impairment mean, and how do you manage this patient then in that context? And this is what's so important about a rehabilitation approach to neuropsychological assessment, is then connecting these dots between the pathology, their impairments, and their daily functioning on a day-to-day basis. How do you help the patient function better day-to-day despite these difficulties, or how can you help them with these difficulties to get on with their life as quickly as possible? And then the second question is do they have any comorbidities or pre-existing conditions that are going to affect their recovery from this pathology and these impairments? And if so, how do you manage those in a way so that they are the least deleterious possible on their outcome? And as we've discussed earlier then, okay, based on those data, what's their prognosis? What can they expect in terms of trajectory of recovery? What treatment do they need? What recommendations do they need for other professionals and the like? So this is kind of another example. If you go to the research and look at visits to primary care doctors, something like 40% of visits to your primary care doctor, the patient mentions difficulties with memory. They are extremely common complaints. And that's because memory, there are many different kinds of memory, number one, and number two, because they're distributed throughout the brain in all kinds of interesting ways, memory functions that is, they're easily disruptible. So you can forget something in day-to-day life, and maybe that's because you have a memory disorder. That is, you had a concussion, or unfortunately you're developing dementia, and you've got brain pathology in the hippocampus or the memory system that's causing forgetting in everyday life. It also may be the case, as I said earlier, that you've got an impairment or a disorder of attention. So if I have impaired attention and I'm not paying attention when I'm supposed to be learning, then I'm going to forget what you said because I wasn't paying attention. Or maybe I have ADHD, or maybe my brainstem has been affected and I have an attentional disorder, so it never got into memory. It may also be the case that I'm anxious or depressed, all of which is deleterious to memory because of the neurochemical substrate behind anxiety and depression. So examine patients with post-traumatic distress disorder, for example, or major depressive disorder. If you give them neuropsychological tests, many of them will have impaired memory. as a consequence. And despite the fact that their brains from a structural and neuroanatomical standpoints are perfectly normal. Sometimes it's because of pharmacology. You can get impairments of memory. So cold medicines, antihistamines, are often deleterious to memory. So you can forget in everyday life because of the medicine you're taking. And lastly, I see this among people like us, unfortunately, and that is people that are, demanding of yourselves. You want to function your best. You want to do your best. You expect yourself to function consistently at your best. Not that I'm obsessive compulsive. No one would ever say that. But sometimes we demand and expect ourselves, and sometimes our environment expects and demands us to do more cognitively than we have resources to do at that time. And so I may think I'm forgetting, and I see so many patients come in their 40s and 50s, and they say, gosh, I'm worried I'm dementing. And you start talking to them, and you find out that this just changed in their job, and this just happened with their kids, and all of a sudden they've got to multitask 14 different issues all at the same time, and they don't know why they're forgetting. And it's because the environmental expectation or demand changed accordingly. So that influences our perception of memory. So you can have a cognitive difficulty in day-to-day functioning, is the point, for many, many, many reasons. And so it's the purpose of the neuropsychological examination to ferret that apart. So I've got some questions. Do programs like Luminosity help with this? So, excellent question. So Luminosity has got some fairly good evidence behind it. There's still a number of multi-center trials going on with Luminosity. The preliminary data is actually pretty positive, which is interesting because although this points out the difference between belief and fact, historically I've not thought that computer-based programs like this could do much, and the data here to date has not at all supported computer-based approaches to cognitive rehabilitation. With that said, there is some data coming out on this Luminosity that's a bit different. I think the reason, one of the things about Luminosity that is so cool is the amount of feedback that the person gets about their own functioning. And so I think that is a very important part of what may connect the dots, if you will. I think you can practice a cognitive task on a computer, but unless it integrates also with your emotional reaction to your own functioning, I think that it may not mean much other than, gee, this is a better score, and so what? But I think if you if you get feedback in a way that really consistently gives you that evidence and displays it in ways that make sense to you, then I think that potentially could be more powerful, again, because it ties into your motivational system. That's purely a theory. I don't know. But in short answer, yeah, there's some preliminary data that Luminosity may be helpful, not only in terms of recovery from injury, but there's also some preliminary data that it may slow the effects of a cognitive decline in aging. So that's cool. Hi, Stephen. You have a question here. Does a stroke fall into the category of TBI? No, is the short answer to that. TBI is usually referred to that issue of, quote, traumatic, end quote. Many of these issues are equally applicable to stroke, however, because they both fall into what's called an acquired brain injury. And acquired brain injuries are certainly different than brain injury that a person grows up with from birth on. So the clinical course and the features and the problems associated with acquired brain injury are more common than not. Other kinds of acquired brain injuries may be well, as you point out, stroke and different types of stroke, like hemorrhage or infarctive strokes, as it's referred to. Also, brain infections, hypoxic encephalopathy, or hypoxia is another kind of acquired brain injury, amongst others. And we see many patients with tumors. And certainly the prognosis from brain tumor, or prognosis for brain tumor, is improving relative to where it was 20 years ago, for sure. So many similarities, many commonalities with CVA, except of course the underlying pathology is different. But many of the cognitive issues have some similarity. So, okay, I'm going to skip over that. And this is domains of the assessment and neuropsychological assessment. And I'm going to briefly bounce over these because I think you know them. This is in a comprehensive assessment. You're going to look at sensory function, different kinds of motor functions, different kinds of language functions, language-related functions like spelling, reading, etc., visual perceptual and visual constructive functions, and then this whole axis of attention, arousal, and attentional control. And basically, this is a brainstem to frontal lobe axis. And it's a reciprocal dynamic axis. So attentional control, we mean focused attention, for example. So right now, you're doing your best to stay focused on one thing and ignoring a whole bunch of other stuff that's still coming into your brain, like your low back pain or whatever. But if your back pain gets bad enough, it's going to intrude up into what you consciously want to pay attention to. That's a whole axis there. And then there are the various types of learning and memory functions that are both verbal and visual, etc. These frontal or executive functions, and so there's things like working memory. Working memory is frequently disrupted by mild traumatic brain injury. Working memory is a different type of memory where it's the kind of memory where you're going into your kitchen to get something and you get there and you now all of a sudden you forgot what you went to the kitchen for. And we all do that all the time, proving the point that memory is disruptible by a variety of things. But working memory exists on an enormous continuum, and these complaints are very common. Cognitive flexibility, problem solving, planning, organizing, sequencing, and paying attention to how you're doing and are you getting where you said you wanted to. There's a question here, have any supplements been found to help these folks? So there is a bunch of stuff out there, and the only supplement that has any data, and any data, I'm being generous, some real preliminary data to suggest that fish oil may be useful. The good news about fish oil is number one, it's not going to hurt you, and number two, we do know it'll help your cardiovascular status, so you may get an extra benefit out of it. And so some people have begun on a real preliminary basis to recommend 200 milligrams of fish oil for these folks. The other thing that is now as a practice standard, there is good research that a medication called amantadine is helpful for cognitive recovery. Amantadine is a medication that was originally, it was originally thought to be an antiviral drug. They thought it was going to be the cure for the common cold. Turned out not to be the case, but they also found that the patients with Parkinson's disease got better. And so now it's frequently used in Parkinson's disorder. But amantadine is now pretty frequently used, particularly in moderate or severe head injury. And I've used it with some patients with mild head injury, and particularly frontal lobe disorders as well. We use a bunch of other medications besides amantadine, including the neurostimulants, sometimes like Adderall or Ritalin. Sometimes we're using The other, quote, stimulants that aren't really stimulants, they're noradrenergic rather than dopaminergic. That is, things like Strattera. And sometimes we're using the anti-Alzheimer's drugs like the acetylcholinesterase inhibitors. There are things like called Exelon or Aricept, for example. Sometimes those patients, sometimes patients with memory disorders secondary to trauma can be helped with those agents. But these are all off-label applications and still a lot of research being done. Okay, so thank you for the question. Good question. Other domains that are assessed in the neuropsychological exam is their neurobehavioral status. Are they impulsive? How is their awareness? Of course, assessment of their emotional functioning, and then also this whole issue of, quote, effort, or is there any evidence of symptom magnification or frank malingering or anything like that? And some people get all whacked out about that. And sometimes it is a relevant concern as well. There's a variety of ways we use to interpret those data. I'm going to briefly comment on those. But the main area where we look at these data, or one of the main methods to interpret these data, involves what are called nomothetic analyses as opposed to idiographic analyses. And I can real briefly share with you what that looks like. So, and there's a very important distinction that isn't often attended to as much as it should be. So you all know the normal distribution, the bell-shaped curve, and so anything within a standard deviation of the mean in each direction is, quote, normal. So if you give a test to somebody that's been given to 10,000 people, and of those 10,000 people, 68% of them fell in this range, and your patient performs in that range, you would say they're normal. So you're comparing their test score, their observed performance, this blue line, to a similar group of people in terms of age, education, sex, etc. So you'd say, well, okay, great, that patient did just fine on that test. And that's what's called a nomothetic interpretation. But what if that patient already was 2.5 standard deviations above average? What if they were a very bright person that had enormous cognitive resources prior to their injury, and now their observed performance is here? Well, now you have a patient with a moderate deficit. So it's really important to benchmark where that patient was prior to their injury. And indeed, we have tests in an examination that can give us a very good idea about where someone was prior to their injury. Grades aren't often a useful, they can be a useful benchmark, but how many of us did our best at school? So that's one issue. Achievement test scores can be useful, but how many of us have test anxiety, or were hung over that day, or didn't care what our achievement test scores were? So they can be useful, but we have 3 or 4 different tests now we could administer to get a pretty good idea about where someone is in this prior to their injury. And Jeff, so Jeff, you were saying something like "sound familiar, Sandy." I don't know what that's about, but I'm sure you and I, Jeff, will have that pleasure at some time. So anyway, and I see you're typing something that I'm sure will be really interesting. Anyway, so when we look at these, we talked earlier about how do you put the whole case together, and this is something that is really important from a vocational standpoint. Jeff is back. We have a case of a high IQ individual who has had a brain injury, bringing him closer to normal. Yeah, okay, so exactly. And what's interesting about that, Jeff, is many people, many providers will react to this guy and say, well, okay, so now you're normal, big deal. But of course, and then particularly people that are used to high levels of functioning become really emotionally distraught. And the metaphor I always like to use on that is if I lose my little finger on my left hand, it really doesn't make any difference unless I'm a concert violinist. And then I'm accustomed to my little finger on my left hand being very good, number one, and number two, really important. And so these folks, these high IQ people, we have to manage and work with them in a very particular way. So this chart, I think, is important for vocational planning and vocational rehabilitation, and we use it in resource facilitation all the time. So let's start at the bottom. When we conceptualize a case, it is individual factors first. Just like you just said, Jeff, who is this patient? And were they a high IQ person? Were they a medium IQ? Were they a low IQ person? Who is this person? And then secondly, what happened to their brain? What's the pathophysiology? So those are the first questions you ask. And so that's why we always get these medical records, et cetera, and why we interview people. The next question is, okay, what are their attendant impairments? What are the motor consequences? What are their neurobehavioral or cognitive impairments? What are their impairments of executive functions or sensory functions? And then the next question is, okay, well, so what? And I'm sorry this slide got kind of messed up, but what are then the functional limitations that they have in day-to-day living? Are they have problems with mobility? Or what about activities of daily living? How does it affect their communication? How does that affect their emotional reactions to things? Where are they at that level? And then what is the relevance of that for their ability to be productive in society or their quality of life? And then next, what are the limitations? And so all of these factors affect where we go with any one given patient. And this is, I guess I would argue, kind of a holistic perspective of that individual, and how do we set the stage for their vocational planning. And a neuropsychological examination is not an examination completed by a non-neuropsychologist. That sounds like a stupid thing to say, but it's not. It's not an intelligence test and a MMPI. That is not a neuropsychological exam. It's not a computerized test. And it's not a non-standardized, what we call qualitative test, like a Bender Gestalt. A neuropsychological examination has to be comprehensive, because otherwise you're not sampling all the relevant domains of brain function. And if you don't do that, you can't draw any rational diagnostic conclusions from which to develop a plan. So I just want to, make sure that we address that issue. Real quickly, I want to just talk about this issue of, quote, malingering. I thought it was kind of interesting that one of the best guys on malingering, his name is Slick, but that's sort of another story, isn't it? Some neuropsychologists have really focused on working, especially with attorneys, defense attorneys, in trying to address this issue of malingering. And malingering, or effort, if you will, is a continuum. My effort varies, I can assure you, from hour to hour and day to day. And it varies as a function of a whole bunch of things. I'm not always 100% on. And our patients aren't either. And in fact, by virtue of a brain injury alone, our, quote, effort, end quote, is more variable. And so we have to be very clear when we use the word malingering what we mean. And this fellow has proposed some diagnostic criteria and certainty around this, which I think is very helpful. So we can talk about volitional exaggeration of cognitive dysfunction, obtaining material gain, or escaping formal duty of responsibility. That's what most people would refer to as malingering. I said it's not a dichotomous variable, but definitely a continuous one. And he developed criteria then for definite, probable, and possible malingering. So the criteria includes the presence of substantial external incentive, and that might be avoidance of returning to work if you hate your job and you don't want to do it. There needs to be evidence from neuropsychological testing from a variety of things I'm not going to go into. And the most important thing is that behaviors meeting criteria from the above that are not accounted for by psychiatric, neurological, or developmental factors. So again, what he is saying is if the patient's engagement, if the patient's performance is less than optimal, but it's due to depression, you shouldn't be diagnosing that patient with malingering. And of course, that makes a great deal of sense. And unfortunately, I still continue to see things happen like that. Or if the patient has an anxiety disorder and they have trouble concentrating. I had a patient in about a month ago that was really demented, and he failed the effort tests. So does that mean he's malingered his dementia? I think he would love to think that were the case. So these tests that we have now of tests of effort are useful, but I think we have to be extremely careful about how we apply their results and how we interpret them. In fact, malingering is a concept that we need to look at on a whole continuum of reactions to our situation. So on one hand, we all know what denial means. So if I find my deficit so painful emotionally, I may need to deny it. Or I may need to minimize and say, well, yeah, I've got a memory problem, but it really doesn't affect how I function day to day. Then what we try to get at, of course, is this issue of acceptance. And then that is, yes, I've got this memory problem, and I'm going to use my memory notebook to compensate for it. And then there's a case that comes in that says, yeah, I've got this memory problem. I've got a memory problem, and I really want you to know I've got a memory problem because everyone else said I didn't, and I know that I do, so I'm going to exaggerate it just a little bit so that you really get it that I'm having this problem. And then there's this patient way at the other end that intends to feign impairment. And I have to say that in my career of the, I don't know how many thousands of patients I have seen, I think I've had 5 or 6 that truly malingered cognitive impairment. The vast majority of us fall in this domain on a day-to-day basis. So anyway, I just wanted to kind of put that in context. I'm going to skip ahead because we've talked about this in the past, and I know all of you may not have been on those webinars, but I want to rock and roll here. So let me see if I want to get into this. Now, so let's talk about vocational reentry. And if you have questions, go for it because we're running out of time. So please send those in now, and I'll work them into this next section. So I don't know how many of these patients you guys get with quote mild end quote head injury. And I know that in a functional reality, a day-to-day reality, we work with many patients with mild traumatic brain injury, and they never get to the VR system because we can get them back to work quickly within, making a few modifications or managing them, and so we'll just go for it, and they may not need VR resources in that respect. But what we do in the vocational reentry process, and that's not true for all patients, by the way, though, there are some patients that I'll purposefully hold out of work until you guys can get engaged with them because there are some circumstances where it will just be essential. But the first issue is a careful neuropsychological assessment, of course, because they've had their CTs, they've had their MRIs, they say whatever they say. But the point is, until we do that, we really don't know what we're dealing with in terms of the functional consequences, the behavioral cognitive consequences of that injury, nor the contextual factors that will influence its expression. The second thing is in a job description and an assessment of the work environment. And by assessment of work environment, obviously that's mostly done through the eyes of the patient. We don't have the resources to go visit their environments usually, although we do sometimes. And sometimes our therapist will go out and do assessments in the work site, depending on the situation. But after you have your neuropsychological data, then you've got to know, what does this person do and how much of what kind of cognitive activity is required to do it well, and what is that work environment like? Is it very intense emotionally? Is it very intense in terms of data? Is it very intense with respect to the number of people around? Or is it quiet? Does the patient work alone? Do they work out of their home? And all those variables are really important. I've got a guy right now with a mild traumatic brain injury. Unfortunately, it is his second one, who is the head of a major IT department. And so this guy multitasks dozens of issues at any one time. His information flow through his corpus callosum would daunt most computers. And so, of course, vocationally, this guy is really vulnerable, much more vulnerable than someone who had less cognitive requirements of their vocation. And I see Beth is, hi Beth. Beth has got a question. Typically, a first neuropsych is done in the hospital. When should the follow-up or a second exam be completed? So yeah, if a patient has had a moderate to severe head injury, they probably have got at least a neuropsychological screening done in the hospital, or at least in some hospital settings. So the question is then when is the second exam being? Well, it kind of depends on what the patient needs from a rehabilitation standpoint. In the acute phase, and by acute I mean first 3 or 4 months, patients are changing so rapidly that neuropsychological data obtained at 1 month may have nothing to do with their neuropsychological status at 3 months. The further out the patient is, when you get into the 3 and 4 and 10 year kind of post framework, you're not going to likely see as much change as you do within that first year. And so it really depends. If I can say that at RHI, for example, we may get some very brief neuropsychological testing, and by that I mean 30 minutes or 60 minutes when they're still in the hospital. But then when it comes out to go into a day treatment program, we may do a full 5 hours of neuropsychological testing so that I can direct the team on exactly what cognitive resources and liabilities there are and how do we work with them. So it kind of depends on what's being planned. On the other hand, if the patient doesn't need that kind of service, and they're flying along and things are going well and so forth, you may not need the examination for further down the road. I think in general, it's probably really important, whether they've had an exam in the hospital or not, to give them an exam before they do return to driving and they return to work. Otherwise, we're potentially setting them up for failure. If you're 3 years post-injury and they had an exam at 2 years post-injury, you may not need a full neuropsychological examination, but it may be important for them to see a neuropsychologist just to find out, to make sure there's nothing else that has changed that would influence their cognitive functioning in that interval, in that year. You want to make sure that the patient has continued to recover. They haven't developed depression. They haven't developed an anxiety disorder. Something else hasn't happened that will influence their return to work capability. So I hope that makes sense, Beth. If not, let me know. Hi, Shell. So you say, have you told us that loss of smell is negative predictor of employment? Yes, it is exactly a negative predictor of employment, as odd as that is. And again, it goes back to the anatomy. Those olfactory bulbs are right there at the base of the frontal lobe. The frontal lobe regulates our emotional behavior. If we're laughing one minute, yelling the next minute, and crying the next minute, most employers aren't very happy with us. And so, as it turns out, olfactory functioning is predictive of your neurobehavioral status, and neurobehavioral status is predictive of your ability to return to work. So yes, a smell test can be really useful. Although they're expensive, we buy ours. They're very expensive scratch and sniff tests, and they come from the University of Pennsylvania, and I think they cost us about $40 per test. Yeah. Hi, Steve. So neuropsych Dr. A and neuropsych Dr. B, apples to apples. So that's a really good question. And that's a really complex one. How do I want to respond to that? Yeah, like any profession, there's a lot of variability in neuropsychologists. I think the first issue is rehabilitation trained or not rehabilitation trained. The vast majority of neuropsychologists do not work in rehabilitation nor were trained in a rehabilitation setting. And so I think for purposes of vocational rehabilitation, it's good to have someone with a rehabilitation background, because that rehabilitation neuropsychologist is going to be focused on rehabilitation. That is helping people resume activities. A lot of times neuropsychologists that are not trained in rehabilitation will write a report. They'll tell you that your patient is brain damaged, and they'll tell you what their impairments are, and then they say thank you very much for your time. Or you get kind of real generic recommendations. And I think that very rehabilitation-oriented neuropsychologists are also very active in treating patients, not only from a psychotherapy standpoint and a family education and family therapy perspective, but also in working with teams of people like, OT, speech, PDT folks, vocational rehab people, supportive employment people. Rehabilitation neuropsychologists are accustomed to working and collaborating with teams of people to affect the patient's needs and goals. So I think the first question you want to ask is rehabilitation trained and focused or not? I think the second issue you want to ask then is the treatment. Are they actively involved in treating people to help them recover from these things? And if you go through those two steps, you're likely going to find the kind of neuropsychologist that will help from a vocational standpoint the most, if that makes sense. Thanks for the question. That's a good one. Yeah, well, so yeah, thank you, Steve. So this assessment of the job description and the work environment, that's a critical piece of putting this piece together. We've got to educate our families and our patients and our employers about this process of returning to work. The patient has got to understand, because they're scared. And if you can give them information, of course that's tools and power. And so they know what to expect. They don't freak out when they have a memory error, because they've been educated. They get a context. They've got a prognosis. They're getting help for it, etc. So this education piece is really important. The employer education is really important. I don't know how many times a week I talk to employers, but it's often, and sometimes employers are scared. Sometimes employers are naive. Sometimes they really want to help the person, and then when the person gets there, It's like, oh my God, I don't know if I can do this. They're human beings too. And so they need to understand what to expect, how to, what is likely to happen, and the like. And so that's a piece that the neuropsychologist and therapy team and counselors and everybody's got to play a role in to maximize the possibility that this patient will get back to work. Some patients need cognitive rehabilitation. So they may have some mild memory impairment, or they may have some mild executive function or attention impairment, and they need 10 sessions of cognitive rehabilitation to help them, get back into optimal functioning. Probably the most important piece of vocational reentry is fatigue management. And when I'm returning someone to work with a mild head injury, I'm usually seeing them at least once a week or every other week during that return to work, that initial return to work phase. We almost never return someone full-time immediately. We'll start them out part-time and titrate them up according to how they're doing. But in terms of fatigue management, understand that we're talking about cognitive fatigue now. And so you know what it feels like to do an 8-hour or 10-hour day and what you go home with in terms of fatigue. For the patient with a mild head injury, they may feel like that after an hour in the beginning. And so I may start doing fatigue management activities with them a month before they return to work. So I'm going to increase the cognitive demands little by little for that month so that I've got them at least to 4 hours before I return them to work half time. And I'll use something called the SUDS, which has nothing to do with bath salts, but SUDS is subjective units of distress scale. So a SUDS scale, what it is simply is a piece of paper with a graph on it, and 100 is really distressed, and 0 is profoundly relaxed, and then everything in between. So I'll have patients doing a SUDS throughout the day with respect to fatigue, excuse me, and any other kind of distress, so that I can see what the pattern is during the course of a day, and so that, number one, to identify how to intervene, but then second of all, to make sure they're making progress. Frequent breaks is critical, and by a break, what I mean is not going to the lounge and talking with your 10 buddies with loud music on and chatting it up. That's not a break. What I mean by a break is no stimulus. Those neurons have got to replenish their neurotransmitters. And so if I go play video games or I get online and start searching for my most recent eBay fantasy, I'm not resting my brain. And I'm not talking about music. I'm not talking about a computer screen. I mean nothing. And usually what I do in preparation is start them on a relaxation training program using a digital recording and get them so that they can really know how to relax and clear their brain, so that when they do take a break, they can shift right into that, clear their brain, restore the cognitive levels, if you will, so that then they can re-engage in the task. So then when it is time to start back to work, we'll start them off part-time, depending on the nature of their injury, how they are in their recovery, what their job demands are, have them continue to monitor symptom frequency. If I just had someone go back the other day, they came back and said, gee, I'm doing really well, but when we increased from 4 hours a day to 6 hours, the headaches started coming back. So what that meant was we had to drop them back down to 4 hours a day for another week or two. Their headaches got better, and then you can start increasing the time again. It was just too much of a jump too quick. And then you monitor the patient and employer satisfaction. So you're going to stay in touch with that employer about how they're doing. You're going to stay in touch with the patient through weekly or every other week return visits, and you titrate and manage and monitor as they go along. So those are kind of some of the main vocational reentry steps. I see that I've managed to babble on now until 6 minutes before the close of our webinar, and it's Friday afternoon. I can't imagine that any of you would be rather doing anything else than to thinking about brain injury, but we've got a couple minutes for questions if there are any out there. I see our eminent Dr. Fisher is typing a question. Those of you who don't know Dr. Fisher, he's the chair of occupational therapy at Indiana University and also sits on the Indiana Brain Injury Leadership Board, which is what guides our HRSA grant and resource facilitation process. So yeah, yeah, Tom, you're a brave man. Well, thank you. Any questions? Well, thank you very much. We got Sandy Culp typing away there. Oh, thanks. Yeah, you're welcome, Sandra. It's our pleasure. Jeff Hughes is typing up. Thank you very much, folks. I think we have another webinar here in the not distant future. I'm not sure about that because I also could have calendar confabulation, which is not uncommon for me. But thank you for your time. All the best, and have a great weekend. Oh, Ted's telling me we have a webinar on Wednesday, March 6th. 12th. Sorry, 12th? Well, no, sorry.
Yeah, that's right, March 6th.
March 6th at 12:30 to 3. So that's a 2.5 hour. Oh, no, so it's 1 to 3. It's 1 to 3 for you. Yep. 1 to 3 on Wednesday, March 6th. So, yeah, all the best. Take care. Bye-bye.